Okay, if you want to take your seats, we'll go ahead and get started. We're fortunate to have the next presentation on accreditation, which has been a very topical issue for many of us in public health over the last probably 15, 20 years. And today we're blessed to have some outstanding speakers on this topic. I'll introduce them all and then call them up individually as we move through the panel presentation. Our first speaker is going to be Dr. Rex Archer, who many of you who were here this morning had the great opportunity to hear his presentation. And I know that this accreditation topic is one that Dr. Archer feels very passionate about. I have worked with Dr. Archer for, 15, 18 years. And one of the first assignments he gave me when I came here to the health department was help us get accredited by Mitch, which was at the time the voluntary accreditation board for the state of Missouri. And we were successful. We were successful in becoming the first local public health agency in the state of Missouri to seek and obtain voluntary accreditation. We ultimately went on to go after FAB accreditation, but it has been a passionate interest of ours, and we're fortunate to have that passion behind those efforts. So, and a lot of that is due to his passion on this topic. Dr. Archer is a graduate of KU Medical School, received his Master of Public Health from the University of Michigan, and, and has been involved in public health even during those times up through now. He's been the director of the Kansas City Health Department since 1998, and he's only 34 years old, so I don't know how he does it. But he has been a strong proponent of public health. It was my pleasure to work as his deputy for the last period of time that I was here at the Kansas City Health Department. So he'll be next, and after that will come Dennis Diehl. Dennis, and I realized I picked Dennis up at the hotel this morning, and Dennis was, I realized as I was driving down to pick him up that we met over 40 years ago, right at 40 years ago, at a CDC TB Today course, Linnell. So, yeah, he was only 10, I was 6. And then Cristi Cain is our next presenter, and she is the director of the local public health program at the Kansas Department of Health and Environment, and she is the coordinator for accreditation for the Kansas Department of Health and Environment. So we're fortunate to have all of these speakers, and we'll have Dr. Archer again present first.
Thank you, Bert. So, 1998, I just come back here to Kansas City, and we had the first joint ASTO-NACHO conference in St. Louis. And there was a speaker there challenging us about why public health doesn't go through an accreditation process. So that's actually where I caught the bug. And then when we had the Turning Point grant here in Missouri, was able to encourage that to actually develop and launch Mitch. And that's kind of how we got started here. And the Mitch process has been a major component, along with several other states, in how the national accreditation standards have been developed. You'll see a little theme here, unleashing the power of public health accreditation. Our National Public Health Accreditation Board, its mission is to improve and protect the health of the public by advancing and transforming the quality and performance of governmental public health agencies in the U.S. and abroad. We're actually entering into contract negotiations to look at another nation in regards to accrediting their public health system. Mentioned this briefly this morning. 80% of the U.S. population is now covered under either a state or local health department. But for the 4-state region, You'll see 8 in Missouri, 6 in Nebraska, 5 in Iowa, 5 in Kansas, all 4 of the state health departments. I think in many ways these are some of the strongest health departments in each of those states. Notice with Kansas, there's one there in the red at the bottom. We have accredited our first military base because public health for a military base, both for the residents and for the service people that are stationed there, all the same 10 essential public health services, the FAB standards apply. And we actually have a contract now with the U.S. Army to be moving through and accrediting all 30-some U.S. Army bases here in the U.S. So again, thinking about this this logic model that you've got in front of you, and if you didn't get a copy of that, I've got some down here. Maybe Bert could pass around if you don't have that, because I think it's useful to look at this. Everybody in this room should be committed to working on the parts of this logic model that are white. Now I'm going to ask a couple of questions. For those of you that are in the pink group here, which means you're a researcher or a faculty trainer or a funder of public health, if you'll hold up your hands if you do any of those types of things, okay? For those of you that are part of an accrediting body, whether that's FAB or Mitch, you're in that yellow category in a sense, hold up your hands. And if you're in the blue, those are various governmental entities that are doing public health. And so I'm going to start there on the far right, and you'll see the ultimate outcome at the top there of improving community health indicators and increasing health equity, and that comes from each of those components up that chain. I do mention there at the bottom the increased capacity for optimal investment in public health and increasing public health's value and role are critical ultimate outcomes. Those can occur if we're not increasing the visibility and credibility of the public health agency, that intermediate outcome, which includes the branding there in red, and that's part of our FAB standards, and improved communication for public health. I won't go into this in a lot of detail other than to say when you look across the inputs and strategies and outputs of an accrediting agency, the bottom bar there, or box that is there in yellow, national consensus standards for public health agencies. So at each stage as we were developing these national standards, we vetted them and got impacted site visits, a whole bunch of stuff that's gone on. We've been funded pretty well from the Robert Wood Johnson Foundation and CDC. We create national consensus standards for public health. So as an example, when we went from public health version 1.0 to 1.5, there were over 500 written comments on those standards that we then, and I was a part of that accreditation committee that was reviewing and updating it from 1.0 to 1.5, that we had to take into account as we improved the standards. Are they perfect? Absolutely not. We're continuing to improve them. That's part of why we're launching our development for 2.0 right now. In the pink area for funders, for our national partners, for researchers, you can see again various types of input strategies and outcomes that come out of that from those groups. And then for the agencies themselves, you see a lot of blue. And that's everything from thinking about it, preparing for it, going through the process. The important thing is that I'm going to show you some evaluation data where we have moved from these outputs to actual short and intermediate accomplishments. So that column there, let's see if my, so this column here, we have data in all of these boxes showing that local health departments that have gone through national accreditation have increased their internal collaboration and external collaboration. They have increased their organization's accountability. They've increased their knowledge of their strengths and weaknesses. They've increased awareness of QI and their culture, and they've increased their understanding of the community's needs and assets. And we're also seeing data already now on efficiency improvements that they're reporting, their organizational capacity issues, their responsiveness on priorities, and their movement more into health equity. So, evaluation is best if it's done independently. So the Robert Wood Johnson Foundation and CDC funded an external evaluator, Nork, out of the University of Chicago, to do this evaluation. And you can see that voluntary response rate from accredited departments, 90% on a voluntary response is pretty good. You can see why people applied. I won't read the handouts to you there. I've got all those slides there for you. But you'll see that they actually then, after they were accredited, 96% believed that it had stimulated their QI and performance improvement. It had identified their strengths and weaknesses. 90% felt that they had better accountability and transparency, and that they had moved forward on their 3 core functions, 10 essential services. And you'll notice that 87%, it has stimulated better collaboration across the health department. And all of us have probably been in organizations where the silos are pretty rigid, and there isn't the kind of communication you'd like to see across different silos. And people are reporting that this process bridges those silos. 82% found that it improved their credibility in their community or within their state. Another 80% saw that they had better accountability to external stakeholders. And 3 out of 4 found that it improved their visibility and reputation. And as I mentioned, if public health doesn't improve its visibility and reputation, we're all going to be out of a job. I'm not going to read you the quotes other than I think the important thing is that they saw better teamwork, and it reinforced that chief role of being that chief health strategist for their community. This just shows the continuation over the years of being part of this process of improvements and greater amount of QI going on. This again shows before and after accreditation in regards to whether they were implementing strategies for QI, how they were monitoring them, and how they were using QI for better decision making. Health outcomes, that takes longer. About 50% are believing they're seeing some health outcome changes. Others are saying still too early. One of the things I really like about this is the second quote, where we're moving from just we're good enough and how we've always done it to becoming great and how we can do things better, more effectively and efficiently. And funding, as our presenter Casey talked about, funding is such a critical issue in Missouri and probably actually in all 4 of our states. You can see that 2/3 felt that they were more efficient. So if you're more efficient, you're freeing up resources you currently have to use in other areas. 44% feel that they've improved their competitiveness for funding, and 31% actually are reporting that they're increasing bringing in funds. When we got accredited in June of 2004, the previous year or 2, we had lost 50 positions here out of 200 for our health department. After we got accredited, our city manager looked at that process, the outside peer review, the extensiveness of it, and we got back 45 of those 50 positions in 3 years. And since 2004, we have not actually lost budget here at the health department. We've gained every year. We've had some programs challenged that we've had to figure out how to deal with, but our overall budget has gone up every year since then. So, people were satisfied, 98% agreed, 79% even found it as the value of the fees. And you can see most are applying. In fact, we've only had 1 health department that has decided so far not to apply for reaccreditation. We have our reaccreditation visit scheduled here in July, so we're in that queue right now to find out how we do on reaccreditation. So you've probably seen this out in the multipurpose room. Public health is an expense, is an investment, not an expense. And I think FAB accreditation is also an investment, not an expense. Other speakers will probably talk about foundational capabilities, so I'll pass over that other than to say that we have crosswalked the foundational capabilities with the FAB standards. And all of our standards, with the exception of one, match up with at least one, and usually the majority of them with 2 to 3 of the foundational capabilities. You'll see standard 5.3 there in the middle, which is strategic planning, is not in the foundational capabilities. I don't know how you can have a health department that doesn't do strategic planning, but it's not listed as a foundational capability. We've then gone through and mapped out all of those measures, because for every standard in FAB, we have 2 to 3 or more measures. And you can see that there are 30 or so measures in FAB that there was consensus development across the country that we needed to be doing that are not under the foundational capabilities. So foundational capabilities are only foundational. I don't know most people that will live in a home that only has the foundation. You need other parts to that. And as you can see here, we're closely aligned also on all the organizational competencies. And the bottom line here is that we're very well crosswalked with this, and we believe that you can use the FAB accreditation standards to show that you're meeting the foundational capabilities. Reaccreditation. More and more emphasis now as we move into reaccreditation on collaboration, partnership, community involvement, leadership, health equity, systems level actions, mobilization of the community. If you remember that graphic cartoon I had up there about where the miracle occurs, and culture of quality improvement. And in the interest of time, I'm just going to flip through those health outcomes and kind of show you the version 2.0 timeline. We've been doing our psychometrics analysis on the standards and measures and our evidence. We've commissioned papers and have expert panels and think tanks going forward in redeveloping for 2.0. I'm actually chairing this process right now. And here's an example of the commissioned papers. You've got the FAB version 2.0. If you go to that link, you can start looking at some of this work that we're doing. And we've already had these think tanks. We've brought all of our site visitors in for, or not all of them, but a series of representative ones to look at that process, where we've had one on health equity, we've had one on behavioral health that's scheduled, we have one on quality improvement. Laboratories was done last year, and we're looking at these, so we're trying to find funding to look at these additional ones for think tanks to continue to evolve the field of public health. As mentioned this morning, the Public Health National Center for Innovation is a subsidiary of the FAB board, and they're the ones that are leading this 21st century process across the country right now, that now Missouri and Kansas are part of. And so ultimately, we believe that we're doing all those components, and I think I'll just stop there. So, Dennis, I think you're next.
Thanks, Dr. Archer. We'll take questions at the end after all three presenters, if that's all right, and move right into the next presentation. We're pleased to have Dennis Diehl, who again is the Executive Director of the Missouri Institute for Community Health, the voluntary accreditation body within the state of Missouri. And Dennis was formerly the Director of the Jefferson County Health Department near St. Louis. And prior to that, he was at the St. Louis City Health Department. So, Dennis, we'll turn it over to you.
Thanks, Bert. So, Dr. Archer spoke mainly about FAB accreditation. I'm going to talk more specifically about the MICH, or Missouri Institute for Community Health. accreditation. Mitch is the accrediting body here in Missouri for a voluntary accreditation program, as was mentioned earlier. And I think there's been a lot of comments made throughout the day about accreditation that touches on both the FAB process and the Mitch process, and I think that should demonstrate to everybody how intertwined accreditation is in all the work that we've been doing in public health these days, including the transforming initiative that Casey spoke about earlier. So real briefly, Mitch is a 501c3 organization. We have a board of directors, and Denise Strehlau, who's here, is currently the president of our board. Dr. Dutzman is our past president. Pretty small organization. We only really have 2 contract employees, one of which is myself. Another is Janet Canavis, a lady who's been involved in public health for a long time. And so the 2 of us try to work with as many of our partners and stakeholders as we can in our program. So I think you'll see as we go through these slides that there's really a lot of commonality between FAB and Mitch in some ways, and then in some differences. I have one slide at the end that does show some of the differences between the programs. But I think the emphasis and the outcomes that Dr. Archer was talking about are very similar between the same programs. So I'm going to talk for a few minutes about the evolution of public health and how we got to where we are with accreditation, among a lot of other issues in public health. So you're probably all aware that there's been an evolution in public health over the years, although I see a lot of younger faces than myself here, so you may not have been involved in as much of it as some of us have. But the evolution of public health, which I'm going to talk about in a minute, has really transformed how we measure the standards of practice in public health and why we've moved to using accreditation. So this is a very general table of that evolution, and please don't be confused. I know Dr. Archer was talking about FAB 1.0, 2.0, but this is a general public health 1.0, 2.0, 3.0. So you can see that for about almost 100 years, starting in the late 1800s, we saw public health 1.0. There's a tremendous growth of knowledge and tools during that period, but there was very uneven access to care and public health. But we saw a lot of improvements and breakthroughs in things like sanitation, availability of vaccines, antibiotics. A lot of those occurred during Public Health 1.0. So we can move on to Public Health 2.0, which basically started around 1988 with the Institute of Medicine Future of Public Health report. I think that's been referred to several times today. And that was involving the systematic development of public health governmental agencies with some capacity across the country. But the focus then was limited to traditional public health agency programs. So now we moved into Public Health 3.0, which really started about 20 years ago, when we started to engage multiple sectors of the health system, public and community partners, trying to generate a collective impact with public health. And we started looking at the influence of the social determinants of health, which we talked about previously today. And so we've been helped or hindered during that time by the Great Recession, the coming and partly leaving of the Affordable Care Act, and the 2012, again, report for the public's health. And one thing about Public Health 3.0, and Dr. Archer mentioned this morning, is that there's been emphasis on public health being the chief public health strategist for the community, and especially the engagement, as it says there, of community partners and stakeholders. So this is another model of a continuation of some that we've looked at already, and you've kind of seen this before. So you have the foundational public health services. Those were outlined in January 2013. And one thing to keep in mind is, and I think again, Dr. Archer mentioned this is a minimum package of services, skills, programs, activities that should be available in every health department. So those are the services. Then you have the foundational capabilities that every health department should have. Those are the skills to carry out the services. And then you have the foundational areas of expertise. One thing that the MINK program adds to those listed in that graphic is emergency response. So just to kind of put everything in perspective from the standpoint of Missouri and the program we have here, I think Bert mentioned, this is a little bit older slide, so it says there are 114 local health departments. So I think at this point there are 113 since the Independence Health Department was discontinued a while back. So they range from large urban departments, such as here in Kansas City, St. Louis, and Springfield, to a lot of small rural departments. Some of the departments here in the state cover a county or an area with as little as 5,000 population, and as a result usually have a pretty small staff, I think as small as 5 people. So of the total health departments, 89 are operated by 5-member elected boards, and that goes back to some of the statutes Bert mentioned, some of which were established back in the 1800s in the state. Those are, at least in part, funded by a mill tax or a property tax, whose rates are approved by the voters of the county. Others are incorporated into their county government. So the local public health agencies might receive also funds from federal grants or contracts, state grants or contracts, and fees that they may charge for some of the services they provide. And again, I think it's been mentioned, Missouri is last in the nation in per capita state funding. Most of the money that goes to the local health departments is pass-through money from the federal government through the state to the locals. And again, we've talked a lot about funding, so sustainable funding is often an issue for the local health departments and as well as for the state health department. So, excuse me. So the system's decentralized. Individual LPHAs, despite their best work, at least for some, have limited influence with the state health department and the legislature. There's been a lack of a unified voice for public health in Missouri. So that's what the Healthier Mo initiative, again, is hoping to improve. And there's been limited collaboration among public health, academia, hospitals, and other providers in the state, in the communities. So those are, we hope, opportunities for improvement rather than barriers that we're going to have to overcome. So, for those of you who might be not quite as familiar with accreditation, for years we've been seeing accreditation programs for hospitals, for police departments, for fire departments, but it's only been probably less than 20 years when accreditation was even considered for public health. But accreditation is a credential given to an agency that meets a defined set of standards and provides a framework. Again, these are the outcomes that have been talked about before: improving quality and performance, relationships with local communities, accountability and transparency, and helping a given agency understand their strengths and weaknesses. Really, the accreditation movement in Missouri really started around 1999. The State Health Department published a document called Defining Public Health in Missouri, which defined the roles that each local health department was supposed to provide. Mitch was established in 2002, and as Dr. Archer mentioned, Kansas City was the first local health department accredited by Mitch in 2003. So over the last 2 years, Mitch has been involved in revising our standards, updating them. We used Public Health 3.0 and the Foundational Public Health Services to establish our new set of standards. And we did that with local public health input. We had at least 70 public health professionals involved in providing comment, suggestion, and input on our standards. So we're trying to keep pace with current practice as we were just talking about evolution of public health. Since I am technologically challenged, this slide was supposed to show our website. For some reason, it didn't show up there. So I just wanted to mention to you that our website is www.mitchweb, so it's MICHWB.org, www.mitchweb.org. And this is the screen that you get when you go to that website, and you can see those, you can click on those, that bar in the blue, and you can find a whole lot of information, probably everything you'd ever want to know, maybe what you might not want to know about accreditation through the Mitch program. Also includes a lot of tools and resources for the folks who want to do accreditation. And so even if you're not interested specifically per se in accreditation, I think if you look through that website, as well as some of the others that were mentioned today, you certainly get a lot of information, a lot of ideas, and a very good feel for what local health agencies can be doing, should be doing, and give you a lot of good information. So, okay, I have a couple of slides here. Not sure if this is going to show up right. Okay, there we go. So this slide and the next slide talk about a couple of the standards in the Mitch process. So we're looking at staff capability and the capability of the health department to address the foundational public health services. So first we look at core competency gaps and strategies for addressing them. Then training in health equity, culturally responsive programs, an agency-wide training program based on a review of the strengths and weaknesses of each employee, a training schedule, and plans for addressing the gaps with future hires. So next we have workforce standards, as I said, to assess the individual staff competencies. So all staff members should have a job description, a core competency self-assessment, what education, training, experience they have had or have not had in core competencies. Based on that, a job training plan. And we asked for a minimum of 8 contact hours of additional training per year for each employee. And that if required, depending on their job classification, a license or certification compliance for their position. So this is just an illustration of the alignment of the 3 different models. First is the Mitch model. One in the middle is Public Health 3.0. And as you've seen before, the third is the foundational public health services. So you can see there is a fair amount of alignment among the 3 models. So this is just a little bit more detailed look at the key components of the 3 different models. So this is a slide that I mentioned earlier, just to show, while The programs are similar in a lot of ways. Probably the biggest difference is not only the fact that we've updated our standards to the foundational public health services and public health 3.0, but there are differences in fees. Otherwise, the cycles are the same in 5 years. Prerequisites are fairly similar, and both do site visits to determine accreditation. So, that's all I have. We'll take questions at the end. Okay, thank you.
All right, you've heard about Missouri, now you get to hear the rest of the story, right, from the state of Kansas. So Christie Cain is the accreditation coordinator with the Kansas Department of Health and Environment, and she'll be presenting how the state of Kansas approaches this topic.
Good afternoon, everyone. How are you doing?
Good.
Good. Okay. So, as he mentioned, I'm Cristi Cain. I am the accreditation coordinator in addition to being the director of the local public health program, which is my main duty. I was voluntold to be the accreditation coordinator in 2015 and kind of took off on this journey after that. So just wanted to share, I was trying to think of, it's after lunch and what would you want to hear about accreditation in Kansas. So I'm just going to take you on our accreditation journey a bit and share some of our top lessons learned, tips, recommendations, things not to do, all that good stuff. So I thought that might be helpful. So the first one is to make it fun. Accreditation can be really intimidating, and so we tried really hard to involve the staff, make it fun for them, make it something that they wanted to be involved with. Before I got involved, I know that there was a lot of negativity around accreditation, and especially so the Kansas Department of Health and Environment is a bit unique for a state health department because we have environment, and so we have a separate division. And it was a real challenge to bring together the two divisions. We actually have three divisions. We have Division of Healthcare Finance, which is Medicaid, that came on board as part of Kansas Department of Health and Environment about 10 years ago. And that wasn't part of our accreditation process. We couldn't use anything for documentation from that division. But it was really about bringing the two divisions together, environment and public health. And environment is like, oh, that accreditation it's a public health thing, and they're making us do it, and they're shoving it down our throats. And so making it fun was one of our strategies for getting environment involved, but keeping public health staff involved as well. And also getting environment to understand that they are public health. Like when I first realized that was an issue, it's like, what do you mean that you think that clean water is not part of public health? And they really view it very concretely. Like I'll never forget one of our comments on our workforce assessment was we asked about cultural competency, and we had about 40% of the environment division that said it didn't apply to their jobs. And one comment was, I work with rocks, not people. And it's like, okay, well, so we've been working on that, so hopefully it's gotten better. But we really are focusing on working across our programs, bureaus, divisions, so that's really important, and recognition is really important. So one thing that we did is when we first uploaded all of our documentation and we hit the submit button, we celebrated that, and then when we officially had everything, like everything was green in EFAB, we printed a big poster and celebrated that, and did articles in our weekly newsletter. So just lots of things to let staff from across the agency know that it was going on, and then also like hopefully encouraging them to be involved. But then really recognizing the people who are working really hard trying to look for appropriate documentation and writing narratives and things like that. So that's definitely something that we focused on. And one of the things we did for recognition, I'll pass it around if you're interested, but this is what, after we became accredited, every person who was involved in accreditation in some way received one of these. We were trying to think, so lots of our staff are in cubes and don't have a place like to hang a certificate or something, and so we were trying to think of something unique. So this has our accredited logo, a picture of our team, a personalized kind of like a certificate, and then we hand wrote a note on each one, and it has a picture of our mascot, who I'll talk about briefly. So we'll pass this around if you'd like to look at it. So another thing we've realized throughout this process is that our locals need support. So Missouri, very similar to Kansas, lots of local health departments, most of which are rural. So you can see our map. The lighter the shade is, the more rural or frontier the county is. You can see Kansas is very frontier or rural. I'm sure none of you have noticed that before. If you've ever driven to Colorado, there's not a lot west of Salina as far as it's very flat and very sparsely populated. So we have exactly 100 health departments. We have 105 counties, but we have 2 multi-county health departments. You can see that 70 of our counties are frontier or rural, and 42 of our health departments have 5 or fewer employees. So keep that in mind, because I'm going to talk about some of our barriers in a moment. And you can see 37 are serving under 5,000 people. We only have 5 health departments that are serving more than 100,000 people. So we have very few large health departments. And as Dr. Archer mentioned, we have 5 accredited health departments in Kansas, one being the state and one being the first military health department. Okay, so every year we do a survey of all local health departments, and the neat thing about this, a couple of neat things. One is that in order to get funding from what we call state formula, they have to fill out this survey. So we have 100% participation every year, which is awesome if you are a researcher. And then the other thing is, because we have exactly 100 health departments, the percentages work out so that you can see exactly how many health departments it is without having to calculate anything. So that's really cool. So you can see how many of our health departments have done CHAWs, CHIPs, strategic plans. And so when we first started collecting this data, probably 2 years ago, it was really depressing. It's like, oh my gosh, like less than half of our counties have done community health improvement plans. Less than a third have done strategic plans. Very few have done quality improvement plans or branding strategies. So we have a lot of work to do. We need to provide technical assistance, but it's really staff intensive. So for example, last year there was a small rural county that was really excited to do a CHA, and this was going to be their first CHA in 25 years. And we helped with that, but again, it's really staff intensive. We don't have staff dedicated to provide assistance around accreditation. We do have a contract with Wichita State University, and they have a staff person who is available to provide some technical assistance, but we actually started the Kansas Accreditation Readiness Project about 4 years ago, where we first started with a 3-hour webinar once a month, walking through each domain. It was a year long, and then it's evolved since then into now really providing direct technical assistance to whatever they need. And so it was really staff intensive at the beginning, and now it's really much more staff intensive depending on how many local health departments are requesting assistance. Right now, we have about 6 local health departments that are somewhere in the process of applying for accreditation. But again, you can see we have our work cut out for us as far as how many local health departments need technical assistance, and we need to inspire them to want to do a CHIP and want to do strategic planning. So we also asked about, so why aren't you doing accreditation, or what do you see as the barriers? And so these are some of the barriers. You can see that staff time was the #1 barrier. And so if you have 3 health department staff in Western Kansas at your health department and you're focusing on giving vaccinations and things like that, then you're not going to have the staff to be able to do accreditation. It's very challenging, and so I think that's definitely one of the top challenges. The process is overwhelming, just even getting started. Where do you start? Who do you involve? And so that's something that we also try to help with, and then not having funding for the application fee. And I think that goes along with their boards of health don't necessarily support it as far as seeing the value in public health. And so it's all about messaging about the importance of accreditation. Using resources. So I'm sure some of you know Shirley Orr and Sonia Armbruster, and we worked with them closely. They were amazing to help us through our accreditation journey. So I would just encourage you to use what resources you have in your state. Either if I know some of you are already from an accredited organization, but as far as helping with reaccreditation, we're definitely going to tap them to help with reaccreditation as well. So they helped us. They reviewed documentation for us. They walked through several practice site visits, practice interviews and things like that, and then helped us at the actual site visit. It's also really important to network with other states or other local health departments who are going through this process. You could get really good ideas, and actually that's how Fabio was born. So Nebraska, who here is from Nebraska? Anybody? Okay. Well, Nebraska, so I'm actually kind of glad that they aren't here because, so they had a mascot, and they were saying how that it really helped, make accreditation fun. And so their mascot's name is Alice, and she kind of looks like a creepy doll. And so that was what our team said. It was like, oh my gosh, Alice is a creepy doll. So when we talked with Nebraska, we had just had a bunch of our measures reopened and didn't know how we were going to prepare for our site visit. We felt like we had been doing lots and lots of work, and it's like, oh gosh, we have lots and lots more work to do. And so we felt like we were headed into the storm, and someone on our team said, well, like buffalo walk into the storm until they get through the other side. And so that is how Fabio came to be. His name is spelled Phabio. And so there were lots of pictures of Fabio. He made it lots of fun. So Fabio has had lots of adventures, but not near as many as Alice. Like, they have all kinds of pictures of Alice all over their state, and we didn't do that. So having a shared drive was really important, where everybody could see documentation while you were preparing it and access it, versus once it was in eFab. So we used that a lot. We also had, so I didn't say this, we started working on accreditation with our SHA in 2011, and we became accredited in November of 2017. So you can tell that was a really long time. And we went through 5 accreditation coordinators in that time. And I didn't count like I thought of it, and A, it would be depressing, and B, I didn't have time before I came this morning, but I would say we had turned over about 25 members of our accreditation team, at least, in that time period, and a couple of them were really core to our accreditation team, and so we were able to bring them back for their institutional knowledge. One was our person who led the SHA SHIP strategic plan, and so without him that would have been a huge challenge. And then we also used our learning management system, not just in Domain 8 around workforce development, but also used it in other places, showing that we had provided appropriate training, and we were able to pull the sign-in sheets out. And so just use what resources you have is one of our tips. And then having a robust accreditation team, so that goes into my comment about losing about 25 people during the process. So you know that turnover is going to happen, so if you only have 1 or 2 people on a domain team, then that might not be a good idea because they might leave even if you hope that they won't or think that they won't. So just making sure that you have diversity on your teams and lots of people. And then another thing that we learned is just that clearly individuals have differing strengths, and so some people are really strong in writing and good at writing narratives and things like that. Some people were just voluntold to be on a domain team and like might not really have wanted to be on it. And so just that was one thing that we really learned in the practice interviews, is that different people have different strengths and being in the interviews might not be one of their strengths. And so making sure to add people. We added people to domain teams after our practice interviews before our site visit. So just that was another tip that we learned, and it's clearly an ongoing process. And so one of the biggest lessons that we learned is that we applied before we were ready, because we were driven by the NIFI funding. And then it went away, and then our accreditation coordinator went away, and we asked for at least 2 extensions because during this time, when I mentioned that we had lots of turnover, we're now on our 4th health department director, after the one who started the accreditation ball rolling. And so I think that's really important, is just making sure you're solid on a lot of documentation and that there aren't any core pieces missing before you apply, because it's impossible to go back in time, even though we wished that we could many, many times. It's also really important to make sure you have consistency across the organization. Just simple things like agendas and sign-in sheets that seem like they would be, a fairly easy request, or having it say KDHE on it, a logo, anything, and the number of meetings that had no sign-in sheet, had no agenda, didn't have branding, and so just having a consistent process was really important. And then Dr. Archer did a wonderful job of talking about a lot of the benefits of accreditation, and I can definitely say we have experienced many benefits. I met with our deputy secretary yesterday talking about our SHA and SHIP process, and it's going to be a lot different this time. There were some things we didn't do well last time. We didn't do a good job of getting input from the general public, and we didn't do a good job of promoting when we were finished with it. And so, that's one thing that we have changed. Everything from, and it wasn't just FAB. There weren't a lot of things that FAB said, you need to improve on these, but they were things that we noticed throughout the process that we went ahead and addressed, like a 24/7 emergency response. Like the director at the time of our state epidemiologist said, well, that's just how we do it. We know we do it that way. And it's yeah, but you have to have it documented so that it is a consistent process. And so anyway, lots of improvements for sure. And then we added this one this morning, and it really plays into what Dr. Archer was talking about really accreditation is about telling the story of your health department, and it is partially through the documentation and partially verbally through the site visit interviews. But really, we don't do well at telling the story of public health and the value and the importance. And so this is an opportunity to do that, but I think more broadly than just focused on accreditation, it's something that we need to improve on as a system. And he mentioned the invisibility crisis. We actually just had our governor's conference last week with 350 people in Manhattan, Kansas, and we had Dr. Umair Shah from Harris County Health Department and the former president of NACHO, and he talked about the invisibility crisis and how we must tell our story if we're going to continue to exist, as Dr. Archer said. So definitely, I would encourage you to look up Invisibility Crisis, get on Twitter if you're not. And so I think that's a great idea, but just storytelling is important, and being able to weave together a coherent story throughout all 12 domains is a huge challenge. Here's my contact information, so feel free to email me or call me if you have any questions or need more information. And then I think I'll turn it back to Bert and we will take questions.
Very good. How about a round of applause for all three of our... Very good. I knew he was going to do that. Okay, how about some questions?
What was that last slide? It was like a cross between a pig and a cow. What was that?
That
It's
was Fabio.
Fabio.
It's a Bible.
Really? Okay.
It's a front view of Fabio.
Pigs now. Okay.
He is offended, I hate to say.
Okay, how about some questions for our presenters? I had one, if you'll allow me, for Dr. Archer, because one of the early discussion points around accreditation, I know I'm going back a ways, but probably around the year 2000 when this was being discussed at the national level, CDC indicated that they would ultimately be rewarding those states, local public health agencies through incentives, either through additional funding or points in their grant applications. And I was going to ask Dr. Archer before he walked out. No.
Trying to hit the front lights on.
Gotcha. If there has been any discussion with FAB on whether or not incentives will be given, real incentives, other than the efficiencies and the quality improvement that we've discussed, but has there been any financial incentives discussed at the federal level for states or local governments?
Yeah. So at the state level, Ohio has pretty good incentives. They passed a law 5 years ago that basically said you don't get state funding if you're not accredited, and gave them 5 years. Now the problem was that they didn't really fund them to help get them there, and so there are a number of ones that are still struggling, but they've really been moving forward in Ohio with that. Believe it or not, hospitals are not required to be JCAHO accredited. But if they want to get funding from Medicare, Medicaid, and various resources, they have to get accredited and try to maintain their accreditation. Our basic strategy has been that until the vast majority of states are accredited, it's going to be difficult for CDC politically to basically say, okay, if you're not accredited, you're not going to get funding. There have been discussions among CDC about starting to maybe give some bonus points on various competitive grants. And I think that's likely to happen in the next few years at some point here, where there'll be some bonus points, not a lot, but a little bit to kind of move it that way. Some of the foundations are kind of taking note of this, and I do think it strengthens your competitive process when we list our track record and the fact that we're independently peer evaluated. I don't think there's any question that our ability to get staff or funding at the local level and support is in part because the city manager and the council know that we actually have rigorous outside evaluation of us and what we're doing and how we do it. I also think that it, and I didn't really mention this, reaccreditation is going to be a little different. It's less on documenting. It's less on documenting and more on narrative and how you tell your story. And so I've actually found reaccreditation to be much more challenging than initial accreditation. But I'm also finding it to be 5 times as rewarding. So as an example of 57 or so narratives that we had to write to tell our story about a particular part of the requirements, I would say 30 of those, when they came to me for review, there were 2 or 3 things that I thought were actually the most important that should have been in that narrative that weren't there. And then I realized I haven't connected the dots for those folks. They don't see that relationship yet. So that then led us to having to have certain kinds of conversations to link things up and connect dots for folks. I also saw about 30, they weren't the same 30, but there was some overlap of critical things that we were doing as a health department that I had no idea that our staff was doing. So it was actually informative for me to get a sense of how people were viewing this issue and what they were doing in our department. But it's not for the weak or weary. But if you really want to take your game up the next notch, I think it's really going to be making that difference. And like I said, from a funding standpoint, there's no question it's making us a stronger department. And there are a number of competitive grants. On our HUD-led grant, as an example, we were the highest scoring across the whole nation last time. So there are a lot of those things that I think are moving forward. I think the public voted for our Healthy Homes ordinance in part because they see us as a credible enforcement arm.
Thanks. Dennis?
I just wanted to mention, I agree, Dr. Archer. Jefferson County was just able a year ago to pass an increased mill tax. The department was established in 1949 and had never had a tax increase until last year. And I think that the vote was positive in part due because we could say we were accredited. So, and I also wanted to mention one thing I didn't say in my presentation was even though Mitch has tried to have as reasonable amount of fees as possible, funding is still a problem for the local health departments. And one benefit we've had, we're currently doing 7 health departments. We had just finished 7 in the last year. So for all those departments, Missouri Department of Health and Senior Services was able to provide 60% of the fees through block grant money. And so that was a huge help. We hope it continues, but it's hard to say whether they're going to be able to do that or not.
We certainly hope so.
Other questions? Yes, Lizzie?
So I work for Wyandotte County, Kansas Health Department, and we're hoping to submit for FAB accreditation in just a few months. But one of the things that I've kind of noticed is a lot of those frontline staff that have been there for 20, 30 years in their positions don't really understand or kind of support the whole accreditation process. So as a supervisor, what's the best way to try to convey to those kind of staff members why we're doing all this work and throwing ourselves under the bus for accreditation?
Great question. Who wants to take a stab at that?
Go ahead, Chris.
I can start off. So that's a great question. And since you're in Kansas, we're happy to provide assistance. We work with your coordinator, Julianne. So I think that there are some great national resources. I know that there are some examples from other states where they have shared like articles and emails and things to send out to frontline staff to kind of help grease the wheel, if you will, like to really get them interested. So you really have to come up with benefits for them, like that will make a difference to them. And so like that can be challenging. Like it's something we can help you with. We can share our articles that we've sent out to staff and emails we've sent out to staff. I know that one of our big things was just like since our leadership changed so often, we had like some varying degrees of leadership buy-in, and so really leadership showing support and voicing support for it frequently, and sharing different ways about the benefits, I think is a huge help. So just showing that leadership buy-in, and like that it's at all levels, and that all levels of management are supporting it, like that supervisors aren't saying negative things about accreditation, or I don't know why we have to do that, things like that. So just making sure that there's consistent messaging across the health department. Anything to add?
I can say that every department that we've accredited, once they've been finished, 100% have said that the process was beneficial to them, made them a better department. And I think one of the things we try to do when we start the process is to tell people, even though there are things you may have to work on that you're either not doing or need to do better, you're probably already doing most of this work. And it's just usually a question of documenting it, which they haven't been doing in the past. So it may look like a daunting task to start, but probably further ahead than they really think.
There's nobody in this room that doesn't know the importance of frontline staff, and they can get disconnected from the overall vision and mission. They may be working on their dailies and not always see the bigger picture. So there are opportunities with this that we don't always do very well to help connect those dots. If you are moving forward effectively in a quality improvement culture, then some of those frontline staff will start to see that change occurring, where they're getting more involved and getting opportunities to change their work environment. When we went through, and we were one of those first 12 or 14 that submitted the first time during that first year, and we weren't ready. And I probably could have cracked the whip a little bit more, might have killed a few people in that process, and so we didn't push it that hard and appropriately. And I'm even on the accreditation committee, but obviously I'm blind to our own application, wasn't in the room for that discussion. But we were assigned an action plan, which we should have been. So I went back to our staff, and we had certain measures that we needed to improve on. And they worked on it. In several cases, to be honest, I've been trying to get our staff to do that for a while, and found it easier to put it into the national standards and have it come down than it was to get them to do it directly. But anyway, so we had to do it. They did it. We then got accredited. And when I went around to thank them for having put that piece together, they said, "Oh, is it too late? We've improved it again." So, you get that buy-in, and what's interesting is, we recently had an outbreak that was involving environmental and our communicable disease folks, and the stuff that we had to do for reaccreditation, that was the boilerplate logic model and plan that we ended up using in that outbreak, and it saved us a whole bunch of time and money. So it's finding those examples, sharing what you're learning from the process, the quality improvement, thanking them for it. With any change, though, you're going to have laggards. You're going to have ones that they'll do what you're asking them to do and not anything more. Yeah, it varies.
Okay, Lizzie. Other questions, comments? I had a comment I was going to share with Christy about, she outlined the challenges that they face with a number of the local health departments not having a CHA, a community health assessment, or a community health improvement plan. And one of the things that I think Missouri has done, and I know we're the show me state, sometimes I say it's the make me state, but one of the things that we've done is to use interns that are available to us through the University of Missouri, Missouri State University, all of our public health programs across the state. And these students have proven invaluable in many of the local health departments to assist. They can't do it on their own, but they can assist. They can be the legs that many health departments need and do a fabulous job. You know, they're given a template, or a template is shared with them from another area that's done it, and they can apply it in the jurisdiction in which they're serving, or they might do more than one. So take that under consideration. I know you've got schools of public health or public health programs in the state, so it's free labor. So,
It's not
so-
just free, it's better than a job interview. When you have an intern that works with you and you get to know them, and when you have a vacancy, boy, it's pretty easy to know who you need to grab.
We've been fortunate here at the Kansas City Health Department in bringing on a number of interns, students that had done their internship here, and then, as Dr. Archer said, what better interview do you have than a 400-hour interview? So, Linnell, did you want to say anything or comment on that?
I love that comment, Bert, because I was just telling Denise, we have 82 interns this summer to play, so.
Can they work in Kansas?
Yeah, we have someone at Johnson County Health Department and another one living here, so, yeah, we are happy to place interns in all kinds of settings, so. And they come with different assets and challenges, and we have an online program, so we have some interns that work full-time. So if you have something that an intern could do over a longer period of time that can be coordinated after hours and on weekends, that's a real unique challenge for us.
Dr. Dutzman, anything you want to add?
Well, same thing, you know, we have students that can go all over the United States and do, and we've got some international. So there's no limitation that way. But yeah, but I think that's true for almost every program, as long as there's an agreement in place between the university and the department, we can do that. So yeah, we've had a few students up with the same process.
Yeah, that is
Great for them.
a great experience for them because it's a great sort of deep dive into descriptive epidemiology, which is a competency area, and sometimes they develop surveys, which is another important skill for them. So it gives them a really good picture of a health department how to do.
Good. All right, any other questions or comments? I think we're coming up on break, or no break?
We're wrapping it up.
Boy, I tell you, she's tough. All right, again, how about a square of applause?